Professor of Surgery, Division of Pediatric Orthopedic at McGill University. Thank you for joining us. This evening we'll be speaking to you about adolescent idiopathic scoliosis and particularly vertebral body tethering. I have the honor of having with me on the panel today Dr. Neil Saran, who is one of my partners that works at the McGill University and Shriners Hospital here in Montreal, as well as Stéphane Parent, who is the department head of Saint Justine Hospital and Department of Surgery. He's also professor of pediatric orthopedics. These are our disclosures. As you see, some of us have been consultant and certain shareholders of different implants related to spinal pediatric deformity. The overarching purpose of the talk is essentially to speak to you about growth modulation, as these are new techniques and develop. Education is at the core of the ability to improve outcome for these patients, and we're here to share our experience and hopefully answer some of your questions. Upon completion of this webinar, we hope that you'll be able to distinguish fundamental differences between spinal fusion and growth modulation using vertebral body tethering. We will be enumerating the clinical indications when vertebral body tethering should be offered to patients with AIS. You should be able to draft and plan levels of instrumentation in preparation for vertebral body tethering. And you'll be able to enumerate the complications related with this new surgical technique. The agenda, as we have laid out, is essentially Dr. Parent will initiate and have a sort of broad discussion about growth modulation and the indication for VBT. Dr. Saran will follow that with his indication for the classic thoracic, but also his experience and indications for lumbar vertebral body tethering. I'll be speaking to you about the complications related to this surgical procedure. And then both Dr. Parent and Dr. Saran will be speaking to you and giving you some tips and pearls as to how to proceed and how to try to avoid those complications. Hopefully we'll be able to do all of this within 25 minutes to 30 minutes, and then we'll be able to discuss a series of cases that highlights our discussions. Throughout the sessions, your microphones are muted, but we welcome and highly encourage you to use the Q&A function, and that therefore one of the faculties will be monitoring the chat, allowing us to answer your questions. Questions we'll mainly address during the case-based discussions, and that hopefully we'll be able to answer all your questions. So here's a bit of the etiquette in respect to the Zoom modality. Looking forward to have a long conversations with you shortly after. Again, a bit of a pitch for the AO Spine. The Global Spine Congress will be held this November in Paris. And it's a in-person Congress that's being held. Other upcoming interesting webinars are on October 16th. We have a cervical radiculopathy webinar. On December 8th, there's the lumbopelvic injuries, lower lumbar, and sacral fracture management. Thank you for your attention, and then we will pass on to Dr. Parent for us to kick off the session for the indications for classic vertebral body tethering. Stéphane.
Thank you, Jean. It's a pleasure to be with you today. Jean asked me to give you my indications, but I think that for the sake of this talk, I'd like to spend some time on the basics of growth modulation and current indications. So these are my disclosures. Of note, I am a shareholder for Spinalogics, and we are currently in a clinical trial to develop a device related to growth modulation. So it's a new approach for the treatment of idiopathic scoliosis. When we say a new approach, when you compare it to fusion, which has maybe 70 years of history, growth modulation is still relatively new, and we are learning, I would say, every day. So if you look at the natural history of a spinal deformity, as you see a patient and he comes to your office, you start with a brace and all that stuff, and you eventually have this patient that will keep on progressing, you can go through the natural history and eventually have a spinal fusion. But what if you could intervene a little bit earlier and then have an option here and try to do something? We know that longitudinal bone growth goes through endochondral ossification, and then intramembranous bone growth occurs in flat bones, especially in the skull. There's two laws that dictate how bone responds to different stresses and stimuli. Utero-Volkmann law is stating that basically when you have too much pressure, you decrease growth. If you have too much tension, you will increase growth on that side. Wolff's law is somewhat different. It says that bone will adapt to loads it experiences. So more load will increase the bone density. So those are the things that you will see when you have bone growth and bone changes. So for longitudinal bone growth to occur, and we'll make a step back and look at this specifically, but it is essential for normal bone growth, and it can be affected in different diseases. We know that angular deformities of the lower extremities are very well known for this, but AIS is also similar to this. It results from endochondral ossification, and the growth plate is really the location of specific activity. So if you look at this specifically, you can better understand what happens with the spinal deformities. And longitudinal bone growth usually stops at the end of adolescence with closer to physis. If you see how longitudinal bone growth occurs, you first have a fetal hyaline model that develops, and suddenly you start having calcification of the cartilage. Then there's a primary ossification center that forms in the diaphysis, and then you have two secondary ossification centers that form in the epiphysis, and then the ossification of physis and bone growth stops at the end of growth. And then what happens in the growth plate? Well, there are three well-known zones for bone growth, but you have the germinal zone, the proliferative zone, and the hypertrophic zone. And these are all essential for bone growth. What happens in the vertebral growth plate? Well, there's no formal growth plate in the vertebra, but there's a growing cartilage, and it forms. It's really at the junction between the disc and the vertebral body. So it's wedged inside, in between the vertebral body and the disc, and a ring apophysis will appear during growth that will progressively ossify until the end of growth. If you look at spinal deformities, they will progress. So first you have a deformity that will appear, and then that's the initiation of the deformity. But what this has as an impact is that this will create asymmetric loading of the spine. And then Utero-Volkmann walks in, and then we have vertebral growth modulation and deformity. So you progressively have a deformity that ensures that this is creating more loading asymmetry, and then you have a vicious circle that will continue. What are we trying to do with growth modulation? We're trying to use Utero-Volkmann principle to limit growth on the convex side and trying to balance the forces that will act on the end plate. So these you'll try to take that vicious circle and turn it into a virtuous circle. So we know that compression slows growth. The impact of growth, compression on growth plate, it decreases the asymmetry of the loads. It reverses vertebral asymmetry, and then you can have progressive correction of the deformity. So it's not clear, but it's not clear yet what happens in that disc during that time.
Idiopathic scoliosis remains a challenging condition.
Sorry, guys. So there's compression-based devices, so staples, hemi-bridge, and then hemi-staples. And then the last one that we have is tethers. So all these devices are compression-based devices, so they try to limit growth on the convex side of the deformity.
Scoliosis-etiology remains unclear, but once the deformity appears, asymmetrical pressure are applied on growth plates, generating
Sorry, guys. So what happens is that you get asymmetric unloading, and that creates an environment for the spine to grow without having asymmetry and then correcting progressively. My current indications for this is AIS. So I don't look at congenital deformities. I don't think patients with syndromic deformities should be treated with this, and certainly not neuromuscular cases. But any patients with a Linke 1A, 1B, which are preferred, and 1C is possible. Any cases between 40 and 70 degrees, and we'll go into cases that worked at 70 degrees and cases that didn't work around 70 degrees. So the bigger the curve is, the more growth potential you need. The smaller the curve is, the more mature you should be. If you start doing cases at 35 degrees and an 8-year-old, then you most likely will have overcorrection and you'll be stuck revising that patient. Premenarchal is usually a good sign that they have enough growth. Risser 0 or 1, Sanders 3 or less is usually what I prefer. Open triaretes and Risser 0 are preferred for bigger curves. So the bigger deformities, you want to have an open triaretes. As for the lower limit, you want to be in patients that are older than 8 to 9 years old, because more growth than that is probably problematic, and over 30 kilograms, because these patients, technically it becomes more difficult to do it under that. And I still tell my patients, although I've been doing this for almost 8 years now, I still tell patients and families that this is an experimental surgery. It's an alternative to spinal fusion, which is a standard treatment at our institution. So if you have a chance and you see a patient that comes in at 26 degrees and they do have a progression, you can have a choice of having a natural history and doing them a posterior spinal fusion, or you can intervene a little bit earlier. But if you have enough growth, you can correct them initially, and with growth, you'll get perfect correction. So any questions at this time? Otherwise, I'll turn it to Neil.
All right, I'm just going to share my screen. You guys see the screen there?
Yes.
Yes.
Perfect. Okay, so thank you everyone for joining us, and thank you to AO and Dr. Willett for inviting me to join this session. It's an honor to be here. So I think Dr. Perron did a very nice job of giving a little introduction and then talking about the indications for thoracic tether. And my charge for this next 5 to 10 minutes is really to discuss a little bit about lumbar tethers, rationale, as well as my current indications. So I think if we look at these two patients, one of them's an 11-and-a-half-year-old, the other's a 10-and-a-half-year-old, and both of them have these curves that are around 50 degrees. And you look at what happens to them. The top one goes on to have vertebral body tethering, has some correction and is still growing, and so this will continue to correct. And the one on the bottom gets a posterior spinal fusion. And you look at the two outcomes and you think to yourself, you think, which one would I want? And I think most of us would jump to the top one. But why are we saying that? Well, we think that there's going to be better motion, but is that going to lead to better functionality? We're not so sure. I think there is some very short-term data that's coming out that's saying that there may or may not be any true functional benefit of the thoracic tethers. Is there going to be less adjacent segment disease? Maybe, probably, time will tell. Are we going to have issues within the vertebral body tether? Are things going to happen in 10, 20, 30, 40 years? We're not really sure. And I think that's why Dr. Perrin, one of the last points that he mentioned was, we still tell all of our patients this is very experimental, and we don't really know what's going to happen in 10, 15, 20 years. When you look at that bottom patient, I know what's going to happen to this patient. I know it's pretty much a one and done surgery. I know they're going to do very well, and they're going to be very functional. So there's pros and cons. Long-term things will come out, and we will see how this goes in the long term. Definitely there is improved range of motion in these patients. They have better flexion, extension, even torsion, and even side bending. And we will see how that plays out over the long term in terms of the long-term results. Now, when you look at the lumbar cases, I think this is where a case can be made that this may have an even bigger benefit than in the thoracic spine. I think if you look at these two patients, there's a big age difference. One of them has literally just started menses on the day that I saw her at the bottom, and the other one's a 16-year-old who's fairly mature. But one of them goes on to a posterior fusion down to L3. The other one has a lumbar vertebral body growth modulation. She's about 13 months out, and her growth is slowing down. And she's got a little bit of imbalance right now, but we'll see how that plays out over the long term. But her spine's not fused. And I think these patients with fusions down into their lumbar spine are more likely to get into trouble in the long term. And that's where this motion preservation might be a lot more beneficial. So number one, these lumbar patients are going to have better motion than the lumbar fusion patients. And then the other thing is, what about adjacent segment disease? I think we do get more adjacent segment disease in patients where we fuse down to L3, L4. And hopefully we're going to see less of that. But again, we don't really know. There's an interesting study that was published in 2012 by Fabricant that looked at really athletic patients, not just all comers. Most of the studies that talk about return to function and return to play really look at all comers, and they're looking at, do they get back to gym class? This paper was really about athletes playing outside of gym class at a higher level and what percentage of them got back or returned to play. And you really see that trend from T11 down to L4. The further down you get, you see that trend with the L4 really dropping off, which makes sense. I think we all see that. And then you look at the con side of this. Again, this is a big unknown. All of the failures that happen with thoracic tethers are still a possibility, and Dr. Willette's going to touch on these, and we'll also get into them during the case discussion. There's some of the approach-related things like psoas and lumbar plexus irritation that occurs with the approach and the implants. There's a question of, are we going to lose lower doses because we're placing this compressive device on the anterior spine? Are we going to lose lower doses? And what's that going to do to sagittal balance? We've seen issues from this in the past, and we know that's really problematic. Is this going to be an issue? And we'll talk about how to try to avoid that. Is there going to be long-term disc degeneration in the zone that's been tethered? We've just compressed the convex portion of the spine. How's that going to react in the long term? We're not sure. Surgical access, we have to cross the diaphragm in these cases. We're going down into the anterior lumbar spine. I think a lot more people are comfortable getting into the thoracic spine than in the lumbar spine. But that being said, when we have these thoracic spine curves that are overhanging, or these 1AR curves where we have to get down to L2, we still do these little mini approaches and do manage to get down there for the thoracic tethers as well. So it's really an extension of some of this work. But I think for a lot of surgeons that don't have that experience, this is a big challenge. All of a sudden, I have to either do some kind of subdiaphragm approach, or I need to do a transdiaphragmatic approach. The other thing is, what about revision surgeries? In the thoracic spine, we can do revision surgeries, but in the lumbar spine, are we really going to go back through the front? I tell my patients this is a one-time trial. If it works, excellent. If it fails, we're going to be moving on to a fusion. There's no way I'm going to be revising a lumbar tether that fails. And so my next slide is really my current indications. It's very brief. And this, with time, we're going to tease out a lot more detail on this. But right now, it's 40 to 60 degree curves that are typically Sanders 2 and 3. I will do Sanders 4, especially for the lower, the 40, 45 degree curves. And then they have to be pretty flexible. I like them to be I like them to bend out to less than 25 degrees. That 25 to 30 degree zone, I start to wonder, is this going to work? And we'll see. So those are my current indications. And with that, I will stop sharing and hand it back to Dr. Perrin to go into the pearls and pitfalls.
So just before that, I'll speak to you a bit about complications.
Oh, sorry, Jeremy.
No, that's okay. That's okay. You cannot start sharing screen. Have you turned off your share screen? Yeah, great. Thanks. So there you have it. You have a good sense as to the indications, and often, people that fail to plan will plan to fail. And that from that perspective, I just want to give you a bit of a heads up as to what are the risks or complications that have been documented and what's in the literature about VBT. So these are my disclosures. And obviously, this is what we want for all our patients. So simple procedure, keep the motion, and you get this phenomenal correction. And that, but just like anything in life, because this is a new procedure, well, there's a learning curve to it. And being surgeons as we are, even though the indications are fairly narrow, fairly straightforward, we tend to sort of become creative and sometimes push the indications. And sometimes we assume that we know what we're doing, and in the end, we may or may not, and therefore we get into trouble and our patients sort of suffer. So that, as you've heard, the long-term results will eventually define and continue to define what are the true indications and when is the best timing to do this and offer this surgery for these patients. So obviously this is not what we want for our patients. So what do we know till now? And to a certain degree, I'll sort of review the literature from that perspective. Now, before I do that, pediatric orthopods understand the concept of growth modulation. So if you put a staple in a knee for angular deformity, well, sometimes you get overcorrection. Sometimes you put a staple in a growth plate that has no growth potential, and guess what? It doesn't correct. And then sometimes you create a correction of a deformity at one area, but you actually create deformities elsewhere. So spinal growth modulation is the same concept, is that there are inherent challenges. And that if you insert a tether and there is too much growth to be had, then you will end up with an overcorrection. If you put in a tether in a deformity that is too large, or that there's not enough growth, then guess what? You will be getting a undercorrection. And then there is also this issue of which levels to tether, and more specifically, how much tension should we be putting that across the segments? Because if you fuse too long, well, the same concept that if you tether too long, then you may be creating deformities elsewhere. And that's so obviously the risk of add-on, the risk of curve progression, or risk of shoulder asymmetry. These are all complications that are related to growth modulation. And if you want to sort of subgroup them into types of complications, you could think about there are procedural complications. And that's really, because of the trend has been that we moved away from anterior approaches, surgeons need to relearn and to start scoping to be able to do this procedure. So you run the risk of hemothorax, pneumothorax, chylothorax. Obviously, you're working around the great vessels, and therefore you may have major blood vessels or a major blood loss, or even what appears to be major blood loss, but in fact is just because you're zoomed in with your stereoscopic camera. Screw positioning, so anterior spinal instrumentation in a deformed spine, the orientation, it becomes critical, and we'll be discussing about that, how to minimize those complications. The other one is device-related complications. Because the spine remains flexible, then one knows that eventually the cable will break. Timing of breakage and placement of breakage and being able to pick that up is obviously something that surgeons need to become aware of. The overcorrection is self-explanatory, bone screw failure, and that has to do with sometimes screw design, as well as screw insertion and screw size. And finally, the third category that I consider is really the executional, the ability to choose appropriate patient, the ability to choose the right levels, getting a sense of over-tensioning or under-tensioning. And again, having a poor growth potential assessment will lead to some of these complications. So nice study sort of done with a cohort of 120 patients, multi-site sort of prospective study, gives us sort of the groundwork as to what happens. So if you look at the hospital stay, essentially there was less than 1% had a complication. It was essentially a pneumothorax that needed a chest tube insertion. If you look at the 90 days, your complication rate goes up to 5%. And essentially, these are complications that picked up once the patient was discharged. If you start looking at a 1 year postoperative, now you're getting into some of the implant complications. And again, 2 years out, you actually see that complications are still rising, and that the return to OR now are becoming more significant and well, maybe not significant, but at least something to keep an eye out for. If you look at the early complications, that's what I was telling you, there was a pneumothorax. If you look at the complications that develop after discharge, essentially we're looking at pneumonias. One looks at a CSF leak secondary to screw malposition. You get pleural effusions that presents with a mild shortness of breath that essentially just resolve, no active treatment per se. If you look again at the late complications between the 3 months and a year, again, there is this CSF leakage secondary to screw. And that may be related to the ongoing motion compared to a spinal fusion, where if you have a minor breach, because everything is locked, it doesn't really generate any issue. Here again, you've got a dynamic spine that is moving. The implants are on constant strain, and that may, again, a slightly malpositioned screw may end up with having complications. You're starting to pick up 6 months out right arm and shoulder paresthesias, secondary to possible repeated surgery and so on. One looks also, and then at the 1 year to 2 year, now you're starting to look at more the so-called curve progression. So in other words, you're not managing the ability to correct the deformity. Deformity is progressing. One has cable failures as well as overcorrection. And that's so this paper gives you a nice sort of cocktail as to what may go wrong. And that, again, as I pointed out, there's technical complications versus sort of device complications and screw pullout and cable breakage. And then there's really this execution, meaning that some of the patients don't do as well. Another nice paper that I just wanted to highlight is really this comparison between posterior spinal fusion and anterior vertebral body tethering. Paper out of JBJS, Peter Newton. And essentially they had a cohort that matched for size and deformity, sort of matched cohort. They follow these patients for the minimum 3.5 year follow-up. And then you sort of look at down the road, you actually see that VBT has a less predictable and less correction of your deformity. And that's in part because some have continued to progress while others had a phenomenal correction. But therefore some indication that your predictability as to how they will do as a general cohort, you may sort of say that from an aesthetic perspective, either rotation or kyphosis may or may not be as corrected. If you look at the unplanned return to OR, there was 9 in the anterior vertebral body compared to 0 for your fusion. If you look at cable breakage, just as a cohort out of 3.5 year out, you actually have 12 patients out of 23 that had a cable breakage or suspect, for which only 3 of these 12 actually required revision surgery. So if you look at the unplanned return to ORs, they actually had 7 patients, of which 2 of them had 2 revisions. And that, again, you look at more the reason for return for surgery is really either overcorrection, which is required 3 revision. There were 3 broken tether that had evidence of curve progression that they went back. One of them had a revision for a new insertion of a tether. One had a addition to deform. They extended the tethering because they felt that the curve was progressing, or they had add-on. So again, basically curve progression, overcorrection, or cable breakage that had a loss of correction. If you look at the functional outcome, granted that this study was not designed to highlight if one was better than the other from a functional outcome, but at the end, essentially 3.5 years out, there's no difference between the 2 groups, and that is from a pain, mental health, image satisfaction, and general function. So I think it's critical that as you schedule patients for this procedure, that the discussion should turn around your consent, and that you should be speaking to them about risk of overcorrection, risk of undercorrection. And as we've highlighted, it really depends on curve magnitude and growth potential. There's risk of additional surgery, and that could be having to revise to a final fusion across the thoracic spine, or that there's add-on, meaning that the lumbar curve has not been controlled or it has continued to progress, and now you need to extend either your tether or you extend your fusion. In essence, you could tell them that they will do as well as this posterior spinal fusion with the added benefit of motion. However, for a long-term outcome, we don't know if that's of better impact on the discs or not. And to a certain degree, the literature is still sort of debating if it's truly better than the traditional surgery. So take-home message from a complication point of view, we know that spinal growth modulation can and will modify the shape of vertebra, and patient curve can be significantly corrected if there's significant growth. That the behavior of the correction is difficult to predict. And we have a few tips and pearls that Dr. Parent and Dr. Saran will give us. The learning curve remains significant. And I would tell you that the follow-up for patients that have VBT needs to be longer than the classic posterior spinal fusion because the complications start showing out after 2 to 3 years rather than the typical PSF. When we say 2 years out, they're good to go. Thank you. So I'll pass that back on to Stefan. And I'll mute myself. If you could go ahead.
You are actually muted right now. There you go. Still muted. Stefan, you're muted. Oh, he knows. Okay. Down at the bottom.
I couldn't get to the so sorry. Let me try this again.
You started your talk, that's why.
Sorry, don't worry. Okay, so I was asked to give you tips and tricks. So I made this small video where I'll go through 5 tips and tricks, and then I'll give you a bonus on how to remove a tether because as my experience grew, I started learning about removing tether. So if you're going to put a tether in, you better be ready to take it out. So, and that's not the same surgery. We'll start with a easy case. That was my second case, 9-year-old, open triareates, wrist 0, 69 degrees, and high risk of progression. We had a long discussion with the family. So, and the first thing we did is that I had the luxury of working with Carl-Éric Aubin, who's an engineer in Montreal. And over the weekend, he did simulation of that surgery over 2 years. So for a long time, we did simulation for all our curves. I don't do it this on a regular matter anymore, but it's something that we still use. Positioning is essential. And I use navigation to find my entry points. It's a thoracoscopic approach, so you want to make sure that you're well located. So I use intraoperative navigation to locate my entry points, not necessarily to put my screws. I know some people do this, but I don't necessarily do this. And then you want to make sure that you see correctly. So the idea is to have a good field of view, and you want to have a dry field of view. So getting to those segmentals is essential. And you have to take the time to get down to these segmentals and cauterize them. I use a harmonic scalpel to do this. Some use a cautery. Sometimes when it starts bleeding, you can use both. And I'll show you what to do when it starts bleeding. But this is when you go slowly, you can really isolate those vessels and get them down all the way down to the bone, and making sure that you have good visualization as you do this. What to do when it bleeds? Well, first, don't panic. So you're hovering on your vessel there, and then sometimes it doesn't take much to have major bleeding to start. You'll see, and what happens then is that you quickly blur your camera, and then you start panicking because you say, well, what's going on? What's happening and all that stuff. So first, take a deep breath. Put something on top of it. You have a peanut or something like that, and then clean up your video camera and go back in. And then what you want to do is look for that segmental more proximally, because as you know, it's wrapping around from the left side to the right. And if you start cauterizing it a little bit more proximal, then you'll be able to stop the bleeding and not necessarily have to open. I have done over 120 VBTs and several revisions, and I never had to open a chest, knock on wood. So with these tricks, you can certainly get away or try at least to limit the extent of the bleeding. So again, please keep your calm and know where your vessels are and isolate them. So you can quickly go down and make sure that it's safe to proceed further. So again, nice dry field. So when you go back to put your screw in, you'll be in a better position to do this. And you're allowed to take a rest in between those segmentals. Screw placement is essential to have a good construct. We use our thoracoscopic view and our fluoro shot next to each other. It really helps me determine my alignment. I also use a pipeline view, so you can go through your instrumentation ports to get a better sense of how well your screws are lined up. There's several papers now coming out that are stating that if you're not perfectly aligned on the sagittal plane, you will have more cable breakages. You can see how I use my fluoroscopy shot. As I start moving in, you'll see I'll be able to put my screw. I can realign, reorient my screw so that I'm perfectly parallel to my end plates. So it gives me a good sense of where and how I line them up. So and this is the old Zimmer system where we had to cut the screws, so you can see that the screws wasn't perfectly round at the end, but that was a smaller patient. So again, good field of view. And then tether placement and tensioning. So I go from top to bottom. Some people go bottom up. Some people go from the middle outwards. I use a technique that I personally call the Tunican opening technique. So you'll see I'll preload my tether on the top. And most of my tensioning is going to be towards the apex. So I preload my set screw, and I will come and grab that tether on the left side. So the tension is going to happen in between the two uppermost screws. I'll take my tether, and then I'll just start to twist it against my post there. And you'll see we'll go over and we'll have a better view, and you can see how much tension I can actually apply just by rotating that handle and just trying to get that tension in. And what you're aiming for is basically bringing that disc at the apex really parallel so that you can do this. So again, same maneuver, not the same patient. We're riding against the post there, and you'll see the twisting motion, and you're pushing down on the spine with your screw at the apex. So you're really correcting, twisting, and getting correction at the same time. So simple maneuver. There are other systems that use a inline tensioner, and it's something that is perfectly okay. It gives you a chance to line up your screw on the next one, and then you cut your cable once you're done, so you get a better view of this. So this was tip number 4 and 5, I assume. And then you see how much correction we got. And again, once you get the patient up, it's very powerful. I mean, if you have lots of growth, like in this kid, and you'll see this patient coming up later on for cases, but you see that how much correction she had initially, but also over time, over 18 and 24 months. And then last tip and trick is how to remove a tether. So second day, when you go back, not the same vision. You don't have a clear chest to go in. You have to take out your adhesions. And really the trick here is to start from the back. You want to work away from the pleura and the pulmonary tissue. You want to go right where your chest wall comes in contact with your instrumentation, and start dissecting from the back towards the front. And then you'll be able to expose those screws and that tether as you go on. But if you try going from the front and trying to expose your screws, you run the risk of getting lung injuries and having a lung injury that will and a leak. So you want to make sure that you're going this. So you're exposing those the screw heads. So you can see that there's significant adhesions on top of the tether. But as we progress slowly, we can expose this scar tissue and then try to expose the instrumentation. You'll see that we'll be able to do this at every level. It's a little bit more bloody. I did remove actually the tether today, and it bled about 100 cc's, which is about double what we have when we put one in. But it's not the same. Like you can see that there's more adhesions. The lung doesn't deflate as well, and your assistant needs to be aware. It's a little bit more challenging for the camera and how we do this. So I do all my approaches myself. So my fellows typically, or my residents typically help me out with the camera. It's a 2-man job usually, but it's or 2-person job. So it's important. Then you have your set screw. You take it off, and sometimes you'll see that the tether is broken underneath it. Sometimes it's not. Sometimes it's just at the junction. And then make sure that you're completely removing or unlodging this tether before you pull on it, and then you can remove it. So these are my tips and tricks. I will turn this now to, so let me just get that, sorry. So before I go on to Neil, I just want to make sure that everyone understands the learning curve for this is significant. This is not sports medicine for a spine surgeon. I think the important points that you have to remember is that planning and positioning is vital for this procedure. You need to be able to access the right levels and not be fiddling around. And the worst thing that can happen is that if you're too anterior, you go into the spinal cord or the spinal canal, or if you're too anterior, you go into the aorta as you put the screws in. So you need to be perfectly positioned. Screw placement is important. Tensioning is still an art in my view. And tether removal, don't plan a big surgery afterwards. Just plan a smaller case because it might take most of your day that day. Thank you. I'll turn this now to Neil.
Thanks, Stefan. So Neil, we're almost right on time. We got 5 minutes to go.
Okay, perfect. So just so there's going to be some pros and pitfalls regarding the lumbar VBT. I think just Stefan's presentation really covers really nicely for the thoracic spine, and really you take pretty much all of those principles, pearls, and tricks, and you translate them to the lumbar spine. And what I'm going to do is touch on some things that are very specific to the lumbar spine. So for me, I use a thoraco-abdominal approach. I take the diaphragm down off of its periphery. And occasionally I still need to use a scope for my upper 1 or 2 screws when I do this. You can do this without taking the diaphragm down. You can do a retroperitoneal approach and then make a small little window through the back of the diaphragm against the spine and hook up to a scope approach above. So there's more than one way to do this in terms of technique. When you get down, and this is a neuromuscular patient. I actually don't have any photos recently. I just realized that when I was putting this talk together, but this is a neuromuscular release I'd done. And so the psoas on this child was pretty small, but sometimes these kids, their psoas is pretty big. And especially at L2, 3, 4, you're really trying to get posterior on that vertebral body, and you need to dissect that psoas off quite well so that you can get your screw positioned appropriately. You can see the segmental vessels, the discs are here, and so these segmentals need to be taken at every level. And the psoas is going to be dissected posteriorly off the spine until you're happy enough that you're posterior. And so when I'm placing, especially L3 and L4 and even L2, I want to be behind the midline of that body. I split them up into quadrants, and I want to go for that second posterior quadrant. I don't want to be in the back quadrant because of the curvature of the canal. If you're right against that back edge, we worry about these concerns about screws protruding into the canal, and especially for the higher ones where there's significant amount of dura and CSF, you could potentially end up with a CSF leak in the long term. So really, I'm aiming for that second quadrant. So I get my staple and screw positioned appropriately on the AP. The other trick I like to use is I rotate my table around so that I have a perfect AP view of the spine. I do this both for my thoracics and for my lumbars. When I'm lined up nicely, you can see the pedicles are on the outer edge. The spinous process is relatively midline. I know that my hand needs to be straight up and down. The only thing I need to do is, do I go caudal or cephalad? And at least it takes that axial plane out of the question for me. And then I go to my lateral, I double check that I'm happy with the position, and then I'm going to go ahead and proceed with the instrumentation. In terms of my levels, it's end vertebra to end vertebra. At the upper end, if this disc is parallel, I'll probably leave this one alone. But if this disc is open on the convex side, then I'm definitely going to catch it. So it's end vertebra to end vertebra. And then the question is, what if that end vertebra is way off the midline? And I wish I had a number like we do in posterior fusions to say, you know what, if it's over 3 centimeters away off the centroid, then really you should be thinking about going to L4. Can I use a bend film to figure out? And I'm not sure anyone really has the true answer on these. But when I do see them starting to get off the midline so far away, I start thinking, should I be going to L4? And then the question is, are you actually going to be able to get there? And if you can, then I think it's worth putting it in. But if you put it in, you really want to have little tension at that level. rather than over tensioning it. And in terms of my correction game plan, so this really depends on the maturity of the patient. For the Saunders 2, I'm going to go for a lot more correction, or sorry, I want a lot less correction because they have a lot more growth left. So I'm aiming for 20 to 25 degrees. For the Saunders 3, I'm aiming for 15 to 20 degrees. And for the Saunders 4, I'm aiming to get them fairly straight. I want to get them down to 10 to 15 degrees. And in that range, if there's a proximal thoracic curve that I'm going to be leaving alone, or sorry, not proximal thoracic, main thoracic curve that measures maybe 30 degrees or so. And I think that if I straighten the lumbar curve out too much, that's going to be an issue. I'll probably leave the lumbar curve on the higher end of that range. Whereas if I think that main thoracic curve is very flexible, or I'm going to do a double thoracic curve, then I'm going to try to aim more for the lower end of that range. The other thing is the proximal segments. I have this tendency to want to crank everything as straight as I can. And what we find is when you over tension those proximal segments, you throw the patient's balance off, because that main thoracic curve kind of just, the upper part of the lumbar curve turns into the main thoracic curve and it throws them off. So you have to be very careful with the upper part of the segment. Pitfalls, the lumbar spine is very flexible, very, very, very flexible. It's so easy to overcorrect it. And at the same time, it's very easy to undercorrect it. This is a 9-year-old. This was actually the first patient that I did 4 or 5 years ago. And she progressed to about 40 degrees. She wasn't wearing her brace. It was impossible to get her compliant. And I talked to the parents about this. We said, you know what, let's do a vertebral body tethering. They were on board, just because if we left it alone, we knew that she was going to end up with a fusion to at least 3, maybe L4. So this was her on table, and I kid you not, I barely felt like I tensioned this in comparison to the thoracics, where I'm cranking on them to get as much correction as I can most of the time. This one, I barely put any correction on it. Curve just went completely flat, and I thought, okay, just like the thoracics, when she stands up, she's gonna bounce, and it'll probably be a 15-degree curve, 10, 15-degree curve, and you can see I really aim for those screws to be behind the 50% line. And then she stands up, and she's got a little bit of overcorrection at the upper segments, and really not a whole lot of curve that's left. And she is tri-radiates have just closed. I don't have her Sanders from then. I wasn't doing it routinely, but I'm guessing she was probably a 2 based on her maturity. And so I follow her along. And maybe in retrospect, I should have taken her back that same week and loosened this cable. But I find it's very hard to know what they're going to do when they first stand up. The lumbar curves are splinting themselves. You don't know what they're going to look like at 4 to 6 weeks out. And then by then, you can't go back. It's just everything's going to be too scarred. So I follow her along, and here she's 3 years out, and we can see she's really overcorrecting. So I say, you know what? I was hoping her growth is going to slow down, but it's not. Let's go and cut this cable. So I went after these 2 levels, thinking that these are the ones that are really overcorrecting. If I take those out, we should be okay. So I took her back, actually removed that screw, and then I cut the cable out here, and I didn't want to chase out this screw just because I was getting down in towards the lumbar level and the diaphragm was there, and I just wanted to make a small incision for that. So I cut the cable there. So I really just left the cable in these 2 segments. And interestingly, she goes on to continue to progress despite me cutting the cable. And so she's 4 or 5 years post-op now, and she's hovering at 35 degrees. You compare it to the first view, and you think, you know what, it's still good, because she's, no matter what happens at this point, she really should never get a fusion down to L3 or L4. But in retrospect, I would have done this differently, and she probably wouldn't have had this portion of the curve turning into the thoracic curve. So overcorrections are a real potential issue. And then here's a 58-degree curve, kind of upper iliac. It bends down to 28. Again, this is also where I'm starting to think, am I really going to do this? And this patient, the iliac crest is actually already got Risser 2 zone. It's a male though, so he's going to grow. And his Sanders actually shows that he's got some growth still. So we went ahead because we had the discussion, and family said, yeah, it makes sense. Let's try to do this. End vertebra to end vertebra. So it's L3. Again, do I go to 4 on this? He's so deep set, there's no way I'm going to get an L4 on this one. and I can't remember what the end vertebral up here was, but I'll show you in a second. So on table and him, I didn't want to overcorrect him, but at the same time, I wanted a decent correction. And this X-ray was taken before the final tightening, but you can see he's pretty flat on the table. And I'm thinking, okay, this should be pretty good. And he stands up at 6 weeks, and he's still got a 35-degree curve. So you know, the tensioning is a little bit off here. How do I figure this out? The nice thing was I put him in a brace, and you can see 3 months out, and he's already, his wrist root, his iliac apophysis is just forming, but he's still growing. He actually grew quite a bit in those first 6 months to a year after the tether went in, and he actually corrected. So a year out, or 9 months out, he's down to less than 30 degrees, and he's actually over 2 years out now and down to about 23, 24 degrees and doing quite well. The tether has not broken yet, so we'll see what happens when that does happen, but I think he's going to be okay. Well, pearls, what do I have to counter this stuff? So this is what I'm going to go into now. So what I do now is I need something to tension against. So I put a small bolster under the lumbar spine, so that I actually have to tension against something. Because putting them flat on the table, you have a pad under their pelvis and their chest, and the lumbar spine just sags. And the other thing I do is I do these stress views. So here's a patient. I've got her, got the screws in, and you can see that she's just, by being on the table, she's actually closed on the convex side, and this is not her. This is not what she looks like pre-op. And so what I do now is I put that screw insertion device back in, and I'm going to crank on the spine and pull it away from the last level. So the cable's in here, and I'm going to pull it to see, can I get this disc parallel? So that's what I'm looking at now. I'm looking to see, can I get that disc parallel? The other thing I look at is the vertebral body wedging. So if I have more wedging, if this angle is more than I want, then I'm going to overcorrect this disc a little bit. So based on where I want to set this patient at the end of the case. Here's another one. So at the end of the surgery, what I'll do is I'll actually check my entire range and see what's happened. So I'm going to load that cable, and I'm simulating gravity to some extent. Now, the only caveat is oftentimes this is limited by my incision. So sometimes rather than using the final screw, I'll actually put this into my second to last screw to really have a little bit of a better sense. And I found that ever since I started doing this, I don't run into these over-under tension issues so much anymore. That's it for the pearls and pitfalls. And Jean, do you want me to, is there anything, burning questions or?
So the Q&A is actually quite quiet. I tried to probe a few people that I knew. So maybe let's, so just from a time perspective, we're a bit late, but if you could sort of just talk to the effect, or maybe Stefan and Neil, you could speak to regarding how much do tension. So obviously, we heard Stefan across the thoracic spine, you're really loading the apex and trying to get things parallel. And then, in your lumbar, Neil, you've seen that if you do that, you get into trouble. So I'm not sure if people sort of understood. So at the end, so at least for me to better understand, you tighten all your cable down to the tension that you think, and then you actually test to see how you think that system is going to behave in a so-called semi-loaded upright position by seeing how much that's going to bend. Is that what you're doing?
Yeah, so that's right. So I'm doing kind of both. I'm doing it segmentally, and then I do it as a whole at the end to double check where I'm at. So I really have an idea in my mind that, okay, most of these discs, I want them parallel when I'm done. And so that's what I'm aiming for. So I'm loading each level as I tension. So I click my tensioner, and then I load it, and I see, where does the disc end up? Does it open? So here you can see prior to loading, it looks like it's over tensioned here. So I'm gonna test and see where it goes. Okay, so I've cranked it out, and it's just getting to parallel. It's not over tension. Now, if the case were that the convex side was open still, then I would try to go for more tension on it. I would try to squeeze it a little bit more, to a certain degree, obviously, and you get a feel for, okay, each click I'm getting something or not. At some point, you just start getting resistance, and you say, okay, I'm not going to keep going. But so I'm doing it segmentally, and then once I'm done at every level, I go back and I test the whole system to see where I've gotten. My upper end, I try to leave it so that the convexity, I'm actually able to open that disc just 2 or 3 degrees, whereas everywhere else below that upper segment, so across the apex, I try to overcorrect it maybe a couple of degrees, and then at the bottom, I'm going for parallel. So at the apex, a little bit of overcorrection of the disc, above and below relatively parallel, but at the upper segment, I want it to be able to open up just a tiny bit.
Okay, great. So a few questions are coming in. So maybe we'll show one case, and before you kick off, the question about exposure. So do we routinely check for Adamkiewicz arteries? And that's from Maria Lee. And then any tricks about how do you put in a screw at L1 and L2 without going through the diaphragm? And I think you sort of addressed that you actually tend to try to cheat. And if you can't, you actually open, you get a scope through the chest to get those upper screws, correct?
Yeah, and I'm not sure exactly how Stefan does it. So my approach is, so I find that the patients that have 11 ribs or really small 12th rib, it's like, so going to T12 on that patient is like going to L1 on a patient who has 12 proper ribs. So that's always something good to keep in mind. I find that on 12 ribs, I'm able to get to L1 relatively easily by pushing the diaphragm down. And then I usually double check on my fluoro that I'm in the right zone. And then I'm going to make a small little nick in the diaphragm, in the crus of the diaphragm fibers with my harmonic, and make sure I plant myself in the right place. It's semi-blind. I think L2, I've done it before, and I only did it once, and I said I'm never doing this again. And if I'm going to L2 or there's 11 ribs and I'm going to L1, I do a little mini open and I take the periphery of the diaphragm down. Or the other option is to do a small retroperitoneal approach and put your screws in there and feed it up to the scope. Stefan.
Yeah, it's very similar. I go regularly down to L1 through the scope, through the chest. I take the diaphragm and lift it up. I use either a peanut or some retractor to lift up that diaphragm, and I get under. The harmonic scalpel that I use is actually a how do you call it? It has this two prongs, and I use the one that's not active to lift up the diaphragm, and I go under with the live part, and I'm able to get to the segmental. So that's one way of doing it. But then if you're not able to visualize completely your vertebral body, I completely agree. Do a mini open, go on your 12th rib, go down retroperitoneal, and then see your vertebral body. And then you can just pass your tether with a 90-degree angle or a right angle under the diaphragm. You don't need to open the diaphragm. You could just leave a small section and just thread it under there.
Okay, so maybe Neil, we'll get you to show the case, and then I'll continue to field some of the questions.
Yeah, and then there was a question about the Adamkiewicz. I have to say I have not encountered for those lumbar curves anything that impressive and so I don't do any special studies prior to going in. Yeah, that's I don't know, Stefan, any thoughts on, have you done any left-sided curves or?
I haven't done a left-sided curve. I'm actually pretty hesitant. If someone comes with a left-sided curve, I don't do it. I'm just too fearful of the short vessels and the proximity of the aorta. I'm not a big fan. But yeah, and then for the lumbar spine and for the Adamkiewicz, I don't look for it. I don't test it, or I don't do an angiogram prior to surgery. I think if you look at the literature, the likelihood of having a spinal cord injury from an abnormal Adamkiewicz in a normal child is almost unheard of. So it's more in terms of if you have a tumor, if you have a congenital anomaly, or someone who walks in and has already the deficit, then that's something that you want to consider. But otherwise, no.
Okay, so gentlemen, if we want to show some cases, we have to get on. Time is whipping by. So show us this case, Neil.
Yeah, we'll go through this one pretty quick. So this is a 13-and-a-half-year-old premenarchal female. Wrists are 0, triradiate's closed. She's got a 46-degree curve that bends out pretty nicely down to 24 degrees. Her lumbar curve is very flexible, almost flattens out. And so, her Sanders score, here it is, it's a 4. So the base of the thumb starting to close, and she's got a bit of fusion on the distal phalanx. And so she's kind of at the upper zone, I think, for myself and probably also for Stefan. But I think a patient who could benefit from a tether. So
upper in the sense that she's a bit almost mature.
Yeah, exactly. The Sanders 4, the issue is that there is growth, but there's not a lot of growth.
Okay.
The good thing here is she's still premenarchal. If I have someone who's postmenarchal and Sanders 4, I really start getting hesitant, especially if their curve is over 50 degrees. Okay. Stefan, thoughts?
Tell me a bit about your bending films.
Yeah, so bending, so we have just a standard side bending, and it's really looking at the flexibility of the curve. And if there are some patients where the curve is bigger and that apex is very rigid, and you wonder, are we really going to do anything by putting a tether in? And I have had a case where the curve only bent down to 40 degrees. This is one of the earlier ones, and I thought, you know what, I think we still probably have a shot at it. But sure enough, it just did not correct. And the reason was the curve was too rigid, and we probably weren't able to offload the concave discs, the concave end plates. So it just never grew, and eventually a tether snapped and we went on to a fusion. So I think the utility of the bend films really is to assess for flexibility of the deformity. You need a flexible curve, otherwise you're not going to be able to offload the end plate so that it can resume growth and actually modulate growth.
Okay, great. Show us what you've done.
Yeah, so she got a pretty much end to end, and center sacral line touches 12, so that's perfect. She doesn't have one of these overhanging curves, otherwise you end up going a little bit lower. So she's end to end. We left her with about a 21-degree curve at, I think this was a few weeks out. And so she actually, over the next couple of years, corrects very nicely down to 10 degrees. The lumbar curve corrected spontaneously. And then another year later, so she's 3 years out. And in looking retrospect, you look back and you say, you know what, she was a little bit off balance. Shoulders are a little off, and maybe your chest is a little bit to the right. And so I think she needed this almost. She broke her cable right there, and curve bumped back up to 22 degrees, which is going to be fine. So did her lumbar curve. Her shoulders look just a little bit better. Clinically, she looks pretty good. Her rib hump's way down. And so I think this one worked out. I don't know, comments from you guys about this?
No, I think it's a great case. It shows you that you go through growth modulation, you get some correction, and it gives you a sense of where the body wants to go. Like that left upper shoulder is pushing it down. So it's pushing at the apex. It's pushing towards the apex of your curve. You can also kind of gather that she gained some weight. So more weight means more stress on the tether, means more stress at the apex. So that's where it's going to break, right? So what we've seen is that it breaks either at the apex or just below. But you end up with a curve under 30 degrees at maturity. To me, that's a win. Great case.
Okay, so I'll hand it off to Stefan for case 2 and 3.
Yeah, so I'll show you 2 cases. The first one is really, Jean asked me to give you a case where there's a cable breakage, but it turns out to be okay. So so this kid, it's the kid that you saw in the video. So almost 70-degree curve, wrists are 0, open triradiate. She's 9 years old. She's tiny little girl, 27 kilograms. So and she had rapid progression. I actually had a ski accident just before she was scheduled to have surgery at 55 degrees. And then 2 months later, she was at 69. So she did progress rapidly. And then we got her down to maybe 36, 37, which today I was answering on one of the questions. I really aim to get them under 35 if I can. But it's not always the case, but you'll see. This patient, so that's immediately post-op, and then at 12 months, you can see that she's starting to correct progressively. And then you will see that later on, Later on, that's 18 months post-op. And then she does come back at 24 months with a broken cable. And she was, at that time, she was still Risser 1. We just went from 69 to about 25 and then bouncing back to 30, 32. So I said, okay, we still have and back then it was we were maybe 2 years into doing this at my institution. I sat down with her again. I said, well, if this is going where I think it is going, with 3 cable breakages, we'll rapidly go back where we stand. So why don't we go back and do it again? So she is now 7 years out and she's under 10 degrees. That's not her last film. I saw her last film. So I think that the drawback of this technique is that there will be cable breakages. There are salvages that are possible. You can go in and say, well, we can go back, but it does have a double hit on the chest wall. But in the end, she was at 69 at 9 years old. So in my book, prior to doing growth modulation, this would have been a anterior and posterior spinal fusion. So she would have an anterior release, anterior fusion, and posterior spinal fusion, and probably a little longer than what we had on this. Because if you look at her pre-op, my levels on this would be at least L1, if not L2, and then she would have had a anterior disc release. But and look at her sagittal plane; she also corrected nicely, and you can see the rib hump who turned out nicely. So I think that in this case, yes, 2 surgeries, but can you really call this a complication? She did have a surgery prior to 2 years, but she ended up being okay after that. So I think in the long term, I consider this a good outcome, but maybe if she only had 1, maybe it would have been better. But I think it highlights the fact that patients need to be followed for the long run. Yeah, go ahead.
Yeah, I was just going to say, these 2 cases sort of highlight what I consider sort of that range, So we have a kid that's older that has a smaller deformity that you are able to sort of get a good outcome. And here's another kid that's really young, has a significant deformity, and you still get a reasonable outcome. So these are the home runs, and that the ability to choose these cases and the ability to execute the surgery really bestows on the responsibility of the surgeons to be able to sort of predict that. And this is where this learning curve, I think, is crucial. Yeah. So let's see some of the cases that maybe did not go as well.
Yeah. So
just before you move on, Stefan, I think this is incredible, this case, right? I think the case that I showed, I think those are your slam dunk cases, your Sanders 3-4, that 40 to 55 degree curve. Those are slam dunks. And I think we're going to see as data comes out that those are the ones where the revisions just don't happen as much. But these cases are the ones where the revisions are super high. Right now is that Newton paper where more than half of them had a triradiate cartilage close, and that's why the revision rate was so high. But the outcome is incredible.
Yeah, if you when you hit you're able to line up a case like this and get it right at the right time with the right growth spurt. I mean, she was growing very rapidly at that time. She was going through a growth spurt. So putting the cable in, not having to wait a year or 2 that the growth spurt kicks in, and then she would correct. I mean, we maybe got just very lucky. And she had a long growth spurt, like from 9 to 13, she did correct over time. So, and then looking back, having the guts to go back at that time, I can tell you the night before going for the revision, I wasn't sleeping that well because I knew that it would be. I heard all these crazy stories about people having to revise these, and it's not an easy surgery to revise. But if you're able to do it, then yeah, no question. I agree with you. I think that in any other hands 10 years ago, this would have been either growing rods, either magic, or a anterior posterior spinal fusion. So I think the outcome's pretty good. For now at least. So maybe
next case.
Yeah, next case. So case number 3 is a bigger case. So and again, this goes back to my early experience. So this patient had barely closing triads, wrister 0, very big curve, 76 degrees. And I think that the other part that today would make me shy away of this is really the flexibility. I don't have her preoperative bends, but this didn't bend down really nicely. So she had a curve that was very rigid. And then the other thing is that this overhang curve and the sagittal deformity was quite significant. So this patient, in retrospect, today I would not entertain doing this as a VBT. Back then, I was still in my learning curves. I had this great case that I just showed you that was just perfect. So I'm like, oh, this is easy. I mean, we can do 70-degree curves, no problem. We can do it. So, but I quickly learned that this doesn't always work. So fairly quickly, I mean, we realized on the first direct that she was at 48, very stiff curve, didn't get much correction. And then obviously, as time went by, maybe a year later, you can see that she was now at 58. So she did add some deformity. You can see it's partly in the instrumentation, but it's also under. And I strongly believe, I've seen this in other cases, that inside on the concavity, if you don't unload them enough, they will continue progressing. That there will be remodeling on the concavity of these vertebral bodies, and they will start progressing. So they will keep on progressing. So this patient came in and she had this very significant deformity, even though we did the tether, and especially with the trunk shift. So what we decided to do at that time is that we had a discussion with family and we said, okay, let's go back and do a posterior spinal fusion. You can see that on the bend films. I mean, it's not perfect flexibility, but it's still there. So there's some motion there. So it's not fused. And the nice thing is that when you go back inside, you can see that the facets, it's like a virgin spine, right? It's just the facets are right there. There's no fusion. The section is the same. So it's not having a growing rod system that you have to work around, remove everything, do the osteotomies and all that stuff. You can do your procedure as you would, except maybe for putting the screws. Some of these screws, like on the concavity, she had very small pedicles, so that's where those wires were coming from. But you can see on the convexity, I was able to put screws pretty much everywhere where I wanted, just navigating those anterior screws. So you go in with your pedicle probe, you hit the screw, and then you decide if you want to go above or below, depending on what it looks like on the X-ray. But I think if you take out all the instrumentation she has in her back, the actual alignment is actually pretty nice. So that's my second case. So that's a case of undercorrection, probably too big a curve, not enough growth, and too stiff a curve.
So Stefan, on the bending film, what would you sort of say that you're looking for? Granted that there's too many cases, variability, but just give us a range of you're saying that you tend to look for a curve that's between 25, 40 and 55.
Yeah. So so my range is right now is I've gone down a little bit, but maybe 35 to 65. The 65, they have to be very, very, very flexible. So they basically have to bend down under 30. So more than 50% of flexibility. The bigger they are, the more flexibility they need to have. The smaller curves, I mean, they will be more flexible, but they don't need as long as they bend under 30, I'm okay with it. But so the 30 mark is actually a very good one. And then the maturity dictates how big the curve can be when you start doing this. So Risser 0 open triads or Sanders 2, in my mind, you can go from 55 to 65. That's still the range that I would accept. Risser closed triads and Risser 0 is 45 to 55, and then Risser 1 is anything under 45. So I don't do 55 degree when they're Risser 1 or Sanders 3 or 4.
Okay, great. I mean, that gives a nice sort of scope as to where we would go. So listen, it's 9:15. I think it would be nice to have that double curve. So if we could ask a participant to sort of stick around a bit longer, I think it would be worthwhile to just discuss this extra case that Dr. Saran has prepared. So go ahead, Neil.
Okay, so this is a 11.5-year-old female, premenarchal. She's Risser 0, Sanders 3. You can see the phalanges are still open. Down here as well, there's the epiphyses are capping more or less. So she's really a true Sanders 3. She's got a 49, 50 degree thoracic curve, which if you look carefully, the apex, he's got these wedge vertebrae. So I start getting worried when I see this, even though it's only a 50 degree curve. I still start getting worried about this. And I didn't put her bend films up, but I have the numbers in parentheses. It bent down to 33 degrees. So kind of right at the limit of is she going to be okay or not? Her lumbar curve, she's got a 52 degree curve. Also has a little bit of wedging, but it's very flexible. It comes down to 19 degrees, like the lumbar curves often are. On the sagittal, if you look, she's got some kind of anomaly. Probably has a spondylolysis down at L5. She has a little spina bifida down there. So I don't know, Stefan, any comments?
No, I agree with you. I think that the thoracic curve is fairly stiff. The flexibility of the lumbar curve is good. Typically, I don't do double tethers, but I think in this case, I think it's probably worthwhile to discuss.
Hey, Neil, can you expand? So, obviously AIS, you tend to see these cuneiform vertebrae. So why are you a bit antsy about that? And can you just sort of expand on that? So, it's a bit like Blount's, I guess.
Yeah, I think so. I think it speaks to the disease in the apophysis and the potential for growth. I think the more deformity you have, the less potential for growth there is. And even if you can offload it, is it really going to rebound? Like, is that growth going to come back? And I'm not sure. So when I do see these wedged vertebrae, these cuneiform vertebrae, I am concerned. If they're flexible enough, I'm still going to treat them. And interestingly, we actually have x-rays of some of these apical vertebrae that are cuneiform. Over time, if the patient's young enough, over time I've actually seen them become more rectangular, which is pretty interesting. But it makes me think this is going to be rigid, and if the patient's a little bit more on the mature side, I'm worried it's not going to work.
Okay, great tip.
So this for me, this is a patient where if we don't do anything, she's going to get a fusion T2 to L3 for sure. And this for me is really where I think if a tether works, it just makes the most sense. And my concern always is, are both of them going to work? I'm already trying to hit a home run with one tether. Now I'm asking myself to hit 2 home runs with 2 tethers. So is this really feasible? And I have to say, and this is exactly the discussion that I have with the parents, is that this is what we're trying to do and this is what we're trying to prevent. Do you guys really want to undertake this? And then I also say that, listen, if the lumbar one works and the thoracic one doesn't, we still have a pretty good bailout, which is a thoracic fusion, and you leave the lumbar spine free. So this discussion happens. And so this patient chose to proceed. So we went ahead, did a double tether. Typically I do these over 2 or 3, like 2 days. So I'll do one day and another one the next day or 2 days later. This one I actually happen to do it all in one day. It makes for a long day. And the tricky thing sometimes is you have to make sure you can offset that screw where you're transitioning from the right side to the left side, but it's actually a lot easier than you think. And so we got her down to 25 degrees thoracic, got her down to about 21 degrees lumbar. She's Sanders 3. Her wrists are still 0, and she was still premenarchal at this stage. And you look at her lateral and you think, you know what, we're starting to get into what's happening here. Did we lose that lordosis, despite the fact that I felt like I got as posterior on her as I can. She's a little heavier set. And so it's harder. I remember her psoas was huge, and I had to work to get to the 50% mark. And so I kept the tether a little bit posterior at L1 and L2 to try to compensate for that. And, we'll see what happens in the long term. So that's kind of her. So here she is 9 months later. There's a little bit of sag in the lumbar deformity. So she's settled at somewhere around 26, 24. She's still Risser 0. And I think she'd had her menses recently at this point, but looked okay. And interestingly, you see,
quickly?
yeah.
People were asking what happens with the kyphosis and the lordosis. See how, as you corrected your lumbar spine in the coronal plane, how you increased lordosis, and similar for the thoracic spine. You corrected, I mean, it's starting to have more kyphosis, but it's also the correction. So it's starting to move. So as you start having your vertebra rotating like this, there's a coupling effect between the coronal plane and the sagittal plane. And that's what's happening. I think that the thoracic spine is getting more harmonious with your lumbar spine, and lumbar spine gains some lordosis there. So it's great.
Yeah. So yeah, absolutely. I think so. Especially in this case, it worked out. And I think I find that in the majority of them, that is the case. And so on her initial standing view, I find that a lot with the lumbar curves. They often sit in this flex position, but I think it's because of the open approach and they just don't stand quite right. When they come back for their 6-week follow-up, this usually disappears and they get their more normal alignment back. So you can see at 9 months, she looks pretty good. So 6 months later, it's the beginning of the pandemic and she's from out of town, another province. She can't come and see me, but she sends me these x-rays and I'm thinking, oh, okay, now what do we do? So she's broken her cable right there. Her curve jumped up to about 32 degrees, still looks okay. The thoracic curve's at 30, the cable looks okay. She's still Risser 0. She's postmenarchal about a half a year now. So we got her into a brace. And again, even if I could revise this, I probably wouldn't, just because it's anterior lumbar. And moving forward another 7 months. So she's now 2 years post-op. You see the cable's broken at another point in the lumbar spine, and it's also snapped mid thoracic spine in the apex. That being said, her curves are still hovering in the low to mid 30s. We keep her in a brace, and another 6 months go by. She's 2.5 years now. This was her most recent follow-up about 2 or 3 months ago, and she's got, you know, a 35 degrees or so thoracic curve, 35-degree lumbar curve. Hasn't really changed a whole lot. She's now over a year post-menarchal, and her Risser signs, she's getting up to Risser 4. Growth is slowing down. And so, you know, we'll see what happens with this one. Time will kind of tell.
I wouldn't touch it. I think.
Yeah, I agree. I think hopefully she's going to sit here. I think the cable's broken enough and her growth has slowed down enough that she's probably going to sit here, you know, moving forward. I think ideally, obviously, I think one of the things you look at in these lumbar curves is the tethers probably break a little bit sooner because there is more motion. And I know she was very active post-op. And also there's the weight issue that you brought up earlier. So these heavier patients, they tend to break their cables a little bit sooner. And from what I've seen, I've had the few of my tether breakages seem to be more in the heavier set patients. We'll see what the literature shows on this over as we move forward too.
So that's great, Neil. So the time has come towards the end of our session. It's at 9:24. I wanted to thank everybody for participating. I don't see any questions on our Q&A. If there are last minute questions, we'll be glad to entertain those. Otherwise, I want to thank the AO North America for allowing us to convey this opportunity to educate and try to minimize the complications and hardships of patients by sharing our knowledge. I want to thank Dr. Saran and Parent for agreeing to help us and transmit their knowledge. Have a nice evening, everybody. And hopefully we'll see you at the next AO North America webinars.